right, welcome back. Part 2. We're going to go through the rest of your drug sheet and it'll be great. All right, we're going to first start off with the sweetest of the drugs on here, glucose, also called glucose 15. And I like the 15, Lynn. I actually like the 15 because it tells me that there's 15 grams.
Oh, that's great.
And it's a good mnemonic. All right, so I use this. We all should use this, but we use it for diabetic emergencies. When someone has diabetes, they're altered, but they can protect their airway, and their blood sugar is under 70. Yep, blood sugar under 70. We give them the whole tube. And the tube doesn't really taste good. I've personally, recreationally, have tried these, and it doesn't taste good. But if it fixes their diabetes, then it's good. All
You know what it's like? It's kind of like some of those gel frostings that you can get in the grocery store and put on cakes, and they actually taste pretty gross, and that's about what that tastes like. Now, the less than 70 is protocol.
Yeah.
So that's protocol that North Carolina has in place. Again, other protocols may be different, but less than 70 is the protocol here.
Great. And how you do it, you're supposed to break off this little tip. There's like a circular tip on there. Break that off, and you should instill it in their buccal cavity. They're not supposed to be swallowing this. It's supposed to be absorbed in their mucosa of their mouth for faster glucose absorption compared to just something eating. All right, and that also helps if they're a little altered instead of coordinating them to swallow. So the contraindications, if they're so altered they can't follow commands, if they can't protect their airway, they have a risk of aspiration. You don't want this junk in your lungs. That I can tell you for sure. How it works is it increases someone's blood sugar, and there aren't any real side effects besides maybe a gross taste. But I've also seen people cut off the other end to give more. You can also squirt it onto a tongue depressor and instill that in the buccal mucosa. But other than that, fairly simple drug.
Okay, good.
Yep.
All right, so next up is ibuprofen.
Yep.
Okay, so ibuprofen, we're going to do this very quickly because you all are probably familiar with ibuprofen. It's a non-steroidal anti-inflammatory. And basically what that means is that it kind of works like steroids, but it's not a steroid. So ibuprofen is used for fever and pain, mostly inflammatory type of pain. We can give this to adults who have fever or pain in the field, and we can also give it to pediatrics. So the dose for adults is typically, these tablets usually come as 200 milligram, and the typical dose is going to be 400 to 800 milligrams for an adult. And for kids, the nice thing is almost exactly the same as acetaminophen. We can give 10 milligrams per kilogram to pediatric patients. Now, for pediatric patients, we're not going to be using tablets. Ambulances typically carry liquid ibuprofen, and we would dose it, and those are usually sweetened, cherry flavor, grape flavor, whatever. So they'll carry actually liquid Tylenol as well as liquid ibuprofen for children. Okay. If we want to talk about some of the contraindications, so again, if you have anybody, these can actually cause bleeding. So if someone's on blood thinners, Coumadin, warfarin, and that type of thing, they should not be taking ibuprofen. Likewise, if someone has a GI bleed or any other kind of bleeding, they should not be taking these. And also, if a person has any kind of allergy, and allergies to NSAIDs can be a little bit more common than allergies to like acetaminophen and stuff. Biggest side effect of taking NSAIDs on a regular basis is they can do damage to the lining of the stomach, and so a lot of people cannot take these on a long-term basis. But in the field, essentially there are very minimal side effects. So if you look at your list, rash maybe, abdominal pain, nausea, diarrhea, constipation, well, those are two opposites, right? Drug doing one or the other. And heartburn. So heartburn usually is going to happen when people have been taking it over a longer period of time and have begun to damage the mucosal lining of their stomach.
Now, how I like to remember it is both the fever reducers, Tylenol and ibuprofen, both affect something in the GI tract as a contraindication. Tylenol's the liver, ibuprofen's the stomach lining, and that's, your mileage may vary with that mnemonic, but it works for me. All right, let's talk about Naloxone, Narcan. All right, so this is a great drug. It is an anti-opiate, and it binds to the receptors that the narcotic is binding to and kicks it off. And so it can reverse an overdose of narcotic overdose. And so if someone has respiratory depression, altered mental status, pinpoint pupils, all the signs, symptoms of a narcotic overdose, maybe you find track marks on their arms, maybe you find spoons and lighters everywhere to tell you that maybe to lead you in the way of a narcotic overdose, then you can consider Narcan. Narcan is an anti-opiate, like I mentioned. How it works is you have a Bristojet, I believe these are called, a Bristojet. It's a needleless delivery system. And yeah, with the power of technology, we'll show you this in real time. You take your Bristojet, you pop all the yellow stuff off of it. You take your Narcan. In here is 2 milligrams of medicine and 2 milliliters of liquid. And we will give 1 milligram in each nair, which comes out to 1 milliliter in each nair. All right, so the medicine we're giving is the milligram, but the volume is the milliliter. And there is a rubber stopper in the vial. And what you do is you put this into the rubber stopper and kind of screw it down to make sure it doesn't screw down anymore. And then we have this fancy device. It's probably a multi-million-dollar device, but it's called a Christmas tree and MAD. We call it the Christmas tree, but it's the, I don't even know what it stands for.
Mucosal
atomizer delivery device. And you see this MAD, or Christmas tree as we fondly call it. We put this, screw it on the top, and you have this assembly, this setup. Exactly.
Should I stick it up your nose?
Yeah, let's not do that because there is, this is a little dirty. But we also, the reason we have this is actually, can we bring the camera back? Yeah.
So you could actually squirt it and you'll see.
Yeah, that's what I want to do, the mist. No, it's full of medicine.
Okay. So see if you can, don't squirt it on the iPad.
No, okay.
You can squirt it.
Oh, wow. Okay. You will have to believe us if it actually is working. But the reason it's important to have this MAD on is if you don't, you just squirt it, a liquid comes out like a string. And Lynn, I apologize for your tablecloth, but I think it'll be okay.
It's just water.
It's just water. Mm-hmm. It's Narcan, Lynn.
No, it's Narcan.
Yeah, it's Narcan. There's other ways to give Narcan. If someone already has an IV, and of course you wouldn't be putting the IV in, but if you're on a paramedic truck, they may have a preloaded syringe of medicine. You would just give the full 2 milligrams and 2 milliliters right into the IV. And
this could also be done IV.
Yes,
because
correct.
This can be, when you put this in here, let's assume it's in there, you can attach that to the IV line. So either of these, yeah. And if you only had this syringe and you had to draw it up out of a vial, for example, because these are more expensive, any kind of fancy packaging is more expensive. So you could have a vial of epi, which looks more like, this is what we mean by a vial. So let's say that was my naloxone, and I had to draw up my 2 milliliters, 2 milligrams. Then I can just attach this device right on there, and it works the same. Now I have a plunger to plunge it through. So either way.
The last way, there's 2 other ways. There's an auto injector that may be out there. Frequently EMS agencies don't use it, but it's out there for the public to use, an auto injector similar to an EpiPen. But then there's also these intranasal prepackaged devices. The dosage varies on them, and so do with that information as you wish, but you put this up the nose, deliver 1 milligram per milliliter in each nair.
Now, I believe, Chris, that these are available for any student, and any student, you know, not suggesting that you necessarily have an opiate problem, but if you want to carry one of these, just like you might carry a CPR face mask or something else, anybody can go over to Student Health and request a Narcan dose, and they look very similar to this, if not identical. Yeah. I believe they told me that the ones coming from Student Health are 0.5 milligrams, which is a pretty low dose, but it might at least get you started. So how do we know we've given the right amount? Well, if you give it intranasally, which is the way that EMTs would give it, it can take a couple of minutes actually for somebody to begin to come around. So biggest problem with narcotic overdose is obviously respiratory depression, which then makes them stop breathing and then they die because they're not breathing. So in the interim, what do you want to be doing? Obviously, if they're not breathing adequately, you have to be bagging them before you give, while you give Narcan. And the idea is not to bring them totally back, because you want to bring them to a point where they are maintaining their own respirations and their own respiratory drive. If we give them too much and they wake up entirely, you basically, not only have you taken away their high, but you also can throw them immediately into withdrawal. And that's not a good experience. And people who come abruptly out of an overdose of narcotics may throw up. They may be very angry and seriously angry. I mean, hostile and aggressive towards the EMS. And if they're in withdrawal, then that sets off a whole other course of things. So our goal with giving Narcan is to restore their respiratory drive. And can we repeat Narcan? Absolutely, we can repeat it. So you give it a dose, you're now transporting your patient, and their breathing starts to slow down again. You can redose them.
So you're saying that these students can get these from Campus Health?
Yes, no questions asked.
All right, well, you heard it here, folks. Everyone come back to UNC campus, go to Campus Health. Get your Narcan. No, you shouldn't come back to campus for that. Maybe when this whole thing blows over, you can come back.
But a number of our students in some of our former classes, I believe, have gone over to get them just because, wow, if something happens and you happen to be in the dorm and somebody overdoses, you can be right there to help them. So no shame in requesting those Narcan devices from from student health.
From student health, yeah. Speaking of spraying things up people's noses, yeah. Why don't you tell us
are you
about?
Gonna put this up my nose?
No, I'm not going to do that.
So the next one you're going to see is basically it's basically an over-the-counter nasal decongestant that some of you may have used. It's Oxymetazoline, which is a long generic name, often more commonly known as Afrin, and that's a very common brand name. And a lot of people use Afrin if they have nasal congestion. And you squirt it up your nose, and it literally clears your nasal cavity or nasal passages so that you can breathe when you have a really bad cold. And it does that by shrinking the vessels in your nose. So
By alpha-1 receptors.
there you go.
Yeah. High yield.
High yield. So, but we don't carry this around in case somebody has a stuffy nose in EMS, because that's not the kind of calls we typically go on. So what do we do with this in EMS? So Oxymetazoline is a vasoconstrictor that we give for people who have nosebleeds. And you can give one to two sprays up each nostril. Okay. We don't really worry too much about the dose, and I'd really have to look at this myself. It's to see how much, I can't even read that, Chris.
Yeah.
How much is actually in that spray? Does it even tell you there?
No.
But 1 to 2 sprays up the affected nostril. So sometimes when people have nosebleeds, basically it's only one side of the nose that it's actually bleeding. So we don't put it up the side that's not affected. Now, in reality, what I have found in using this is that when somebody has a really bad nosebleed, it's kind of pointless to be spraying something up there as blood is just draining out, because medicine just comes back out. So in my practice, I found it most valuable that when you finally are pretty much getting a nosebleed to stop, that's the time that you want to use the Oxymetazoline to just kind of almost like finishing touch to now constrict those vessels so that it can help it stop bleeding. More effective, and you will learn. Did we already do epistaxis? I can't even remember, but I believe we did in trauma. But you want them to lean forward, pinch the nostrils together, hold those nostrils. Sometimes putting a cold pack along the bridge of the nose can help, and you can use Oxymetazoline towards the tail end of a nosebleed. A couple things to be concerned about. So hypertension. Hypertension, this is a vasoconstrictor, and various protocols will differ on what the top end of a systolic blood pressure is for not giving Oxymetazoline. I believe, if I recall, I want to say it was a diastolic of 110,
yep.
And was there a systolic of 220?
I don't know.
Something or other.
But
diastolic of 110, I can't remember what the state protocol is off the top of my head. And a lot of times, you might see that because people who are extremely hypertensive often, especially if they're also on any kind of blood thinners or whatever, may wind up with nosebleeds. And I can tell you, some of those nosebleeds I think I've been on scene an hour or more with people who have nosebleeds and they don't want to go to the hospital. So you want to just be a little careful of using oxymetazoline if somebody is having a nosebleed because of a hypertensive crisis or emergency.
Speaking of high blood pressure, low blood pressure is a contraindication for our next drug.
Yeah, there you go. So, next up.
Yeah, next drug.
I'm having chest pain.
Oh, because that segue was so bad.
That's right.
Okay. Yeah. We're going to talk about nitroglycerin. Probably my close second favorite drug. I like albuterol so much, but nitro is up there. We use it in EMS for two reasons. Chest pain, also called angina. Not angina, but angina.
Or heart attack.
Or a heart attack. Yeah. But
chest pain from a heart attack.
But yeah. You can't figure that out in the field. Okay, so angina, chest pain, just chest pain. Not traumatic, like I didn't hit you in the chest and you're like, oh, my chest hurts, now give nitro. Not that. Medical chest pain or pulmonary edema. And I'll defer pulmonary edema to Lynn because she has a very good story about giving like 1 million doses to someone. But as a paramedic, not as an EMT basic, so it'll differ a little bit. But for chest pain, we give 0.4 milligrams per spray and per tablet. So this is sometimes confusing for students because on, I think, the PowerPoint, it says 0.3 milligrams a tablet and 0.4 a spray. I just looked on here, it's 0.4 milligrams a tablet.
Some tablets are 0.3.
Yeah, so basically 0.3 to 0.4 is what you should know. Actually, on here it says, ooh, I like this, 400 micrograms. Oh my gosh, how do I get milligrams from that? 0.4 milligrams, okay. It is sublingual, that is high yield. You have big blood vessels underneath your tongue, and so you want to instill that medicine under those in those blood vessels. You can give for chest pain and for pulmonary edema, but we'll defer pulmonary edema in a second. You can give one dose every 5 minutes up to 3 times. So how you would see that written on your sheet is Q 5 minutes. Q means every 5 minutes times 3. And that would be over a period of 15 minutes max. How it works is a vasodilator, and so it reduces preload to the heart, it reduces afterload, and it vasodilates your coronaries. And so all those factors, some more than others, but in general, what you should know is all those factors help reduce myocardial oxygen demand. And when demand outweighs supply, your heart muscle gets irritated and expresses its frustration as angina. All right, so that's what we use it for. The contraindications, head trauma, I'll let Lynn talk about that. ED medications, that's high yield. So Viagra, Cialis, Levitra.
Those are the main 3.
Those are the main 3.
Yeah. State protocol is 48 hours.
48 hours.
Yeah. Now, they each vary. Viagra is actually 24.
Yeah.
I think Cialis is 48 and Levitra is 76 or 72, but state is, and most protocols just say flat across the board 48 hours.
And the reason that is ED drugs vasodilate themselves. And so you if you add on a vasodilator with another vasodilator like nitro, you could precipitously drop someone's blood pressure. And so that is no bueno. So we don't want to do that. You can reason through that if, hey, I'm going to give this medicine and it's going to drop someone's blood pressure. If their blood pressure is already low, I don't want to give it. So a systolic under 90 to 100. So 90 for your book, but 100 for North Carolina. So you will be tested on.
Well, I will never ask you in a test. I
That's
won't
not
give
fair.
you 100 or 90 as your options.
100 is a good number.
Yeah.
Just know 100.
Yeah.
It is given in the sublingual tablets or spray. At EMS, I've usually only seen the spray. People who have a prescription will carry around the tablets themselves. And then, of course, the side effects is a lower blood pressure. But if we're in a normal range to begin with, it'll be okay if we drop a little bit. And so before you give repeat doses, you should check another blood pressure because you could theoretically drop to below your threshold to give another dose. And then high yield clinically is patients tend to have bad headaches on nitro. So warn them that ahead of time. But I'll let Lynn finish off with nitroglycerin for pulmonary edema if you want to.
Yeah, so just a couple other things on nitro. So just remember, if you are giving tablets or helping someone take a tablet, they're very tiny. We'll show you what one of these looks like. They're really, really small. So there's a tablet. They dissolve very quickly. And they talk about tablets in your textbook because a lot of places only allow you to help a patient use their own nitro, and patients aren't typically going to have sublingual spray at home. In North Carolina, you can give them nitro from the EMS supplies using the sublingual spray, provided that the patient has a prescription for nitro. So if they have a prescription, then you have standing orders to go ahead and give sublingual nitro. If they do not have a prescription and you do suspect that it's a chest pain call, you should call medical control and get orders for it. Another thing about, Chris mentioned the contraindications of the drugs that you have to make sure people aren't taking. So just be aware that if you ask somebody in your sample history, what medications do you take? And that patient tells you, well, I take a blood pressure drug and I take insulin. You have to specifically ask them, do you take any erectile dysfunction drugs? Because patients might not tell you that, either because they're embarrassed, so they don't want to admit that they use them, or they use them so infrequently that they don't really think about it when you ask them what medications you take on a daily basis. So if they're taking them every day, they're having a great time. So then they might remember to tell you, but who knows?
Yeah.
All right. The other thing with nitro is, so not only blood pressure, but another contraindication is a heart rate less than 50 or heart rate greater than 100. So you don't want to give nitro with those either of those extremes on heart rate.
And I understand why it helps with chest pain, but how does it help with pulmonary edema?
Okay, so, well, Chris, glad you asked.
Yeah.
So what happens, you all know that, you should know by now that we have pulmonary edema from congestive heart failure is because the pump is failing. And if your left ventricle fails, then you get pressure build up back into the lungs. And what happens is that fluid begins to push out of the circulatory system into the alveoli, into the lung tissue. So if we make the container bigger and we increase the size of the vessels, then we reduce the resistance and the pressure that's in the lungs, and it helps to draw some of that fluid out as well as prevent further fluid from flooding the lungs. So nitro can be very effective for pulmonary edema. Back when I first started EMS, we did not have CPAP. And so this was the only weapon we had against congestive heart failure and pulmonary edema. I can say that now CPAP far outweighs nitro as far as a beneficial treatment. So CPAP really is your first treatment of choice for severe pulmonary edema. Now, that doesn't mean that you might use nitro when you first arrive on scene and you want to get something on board, because it's going to take you a few minutes to set up CPAP, and some patients won't allow you to use CPAP, as you saw in some of the videos that you should have watched under the respiratory section. So for an EMT, you can give up to 3 sprays of nitro once every 5 minutes for pulmonary edema. The same contraindications apply, and the same requirement that every time you go to give nitro that you must check a blood pressure and make sure that your sprays haven't reduced the pressure below that threshold of 100. Most pulmonary edema patients will have very high blood pressures. And when I say high, we're talking, systolic of 160 to 180. And I can't even think of a time, and went to plenty of pulmonary edema calls where a patient actually had a low pressure. And if they had a low pressure, that means they were really in bad heart failure, and they were probably altered with a lot of other problems. So, so we can give nitro for pulmonary edema, 1 spray every 5 minutes, up to a maximum of 3 times. And you just got to be careful if there is any kind of head trauma involved. So if you had, for example, someone had a poisoning overdose And let's say, which you'll learn when we do toxicology, but let's say they inhaled like chlorine gas or something like that, and they wind up with pulmonary edema. It's a very different underlying problem. This is not a pressure problem. It's a leakage problem. And so with that kind of fluid buildup in the lungs, nitro is not going to help because it is not a heart failure pressure problem. So you want to make sure that your pulmonary edema is being caused by an underlying congestive heart failure problem and not some other reason. Okay.
That's a great point. Yeah. So in the cardiovascular, maybe respiratory lecture, I do talk about the difference between cardiogenic and non-cardiogenic pulmonary edema, and this is for cardiogenic pulmonary edema.
Yeah.
Great. Well, that is part 2.
Alrighty.
Yeah.
So so we're done with this, and now our next, we need to take a 30-second break.
Yeah.
We're going to start the next video, and we're going to show you how to do injectable epinephrine.
Yeah.
See you in a bit.